Welcome to the health education program of Vasavya Nursing Home. This is 1177th weekly health education program. In this health education program, we are giving expert speakers speeches and their lectures regarding on development of medical sciences. Today, one eminent person with us, he speaks on critical care. We have seen the importance of critical care during pandemic of COVID-19. And also every day we seeing the importance of critical care in a brain stroke, heart stroke, and other metabolic disorders, and the respiratory syndrome, like that. So many cases, medical cases, we seeing the importance of critical care. Today's topic spoken by Dr. S. Hariharan is Professor of Critical Care Medicine Specialist, University of West Indies. He speaks on critical care. And in this critical care, sometimes have good, sometimes bad things also. And how to justify this type of critical care, the practice in a healthcare problem. Now, over to Dr. S. Hariharan. I told you, he is a professor of critical care medicine, University of Health, West Indies. Over to Hariharan.
Thank you, Dr. Samaram. As Dr. Samaram said, this is a very advanced topic in the sense that there is a lot of technical issues with the critical care. What I am planning to do today is to tell you about the importance of critical care and how we used critical care during pandemic, and also how critical care should not be used. Sometimes for money purposes, in many hospitals, ICU is being abused, and sometimes in the public healthcare system also, because of many other factors which I am going to touch you upon, ICU can be misused. So I just wanted to touch you and give you an overall opinion on how critical care was useful during the pandemic and how we should use critical care. So I'm going to tell you about the pandemic, what are all the respiratory disorders, and what are the criteria for admitting patients into ICU, and what do we do with the ventilators, and how do we triage patients, because during pandemic so many people required ICU. So what criteria we are going to employ to actually triage patients and take them into ICU, and how ICU is being abused, and what are the ethical and legal considerations in critical care. Now, in the recent times, we had plenty of respiratory disorders as pandemics, which was the avian flu was there, swine flu was there, influenza B was there. In 2003, the first SARS-CoV-1 came, and then that actually went to many countries. The Middle East respiratory syndrome came in the mid-2000s, and luckily it did not spread much. Then came the SARS-CoV-2, which we commonly known as COVID-19, and we are still under the effect of that particular pandemic, and we lost millions of people throughout the world, and how critical care was helpful in this situation. If you see the overall spectrum of COVID-19, almost 80% of the people had only mild illness. 81% is overall international statistics. The severe illness was in 14% of people, and then only 5% of people actually became critical and required either what we call as a high dependency unit or a ICU. So if you see the statistics throughout the world, the number of COVID patients, the proportion of COVID patients who were admitted into ICU ranged from 5% to 26%. In some countries, so many people were admitted into ICU. And if you see the death associated with COVID, overall it was around 2 to 2.5%. But people who are above 80 years had a very high mortality, which was 15%. And 70 to 79% had 8% mortality. And people who were admitted into ICU, almost half of them passed away, unfortunately, because ICU treatment with all its benefits, in COVID, we had a lot of mortality, which is 50% mortality, which is far, far higher, and I will tell you why. So what are the criteria which we used during COVID for ICU admission? When there was very severe deterioration in the oxygenation, what we call as hypoxemia, when there was worsening comorbid conditions is diabetes, high blood pressure, ischemic heart disease, asthma, severe bronchospasm, cardiac problem, renal kidney problem, neurological problem, which is seizure or coma, and these are the comorbid problems. When they get worsened, we actually admitted them into ICU. Now, the majority of COVID patients came into ICU for respiratory critical care. So they had to be put on ventilator. They started decompensating. The worst part of it is that the chest X-ray was not showing any signs, which we commonly see in severe pneumonitis patients. We will see a lot of opacities, what we call as a white patches in the chest X-ray. And in COVID, it was not correlating with the degree of oxygenation impairment. And we could see that, everybody had a pulse oximeter at home, and they were starting to measure the oxygen, and it was gradually increasing, and that was the sign of respiratory failure. And they all went into what we call as ARDS. That's called an acute respiratory distress syndrome. Now, there are many definitions for ARDS, and this is the latest definition, which we call as a Berlin definition, which we actually used to classify the ARDS for these patients. And then what we did is then we put them on the ventilator. So we had clear protocols which were associated with a good benefit and a good outcome of these COVID patients. But there were some routine things which we used in ventilator which were not useful. And at one point of time, there was a lot of scientific information which said that if you put a patient on a ventilator when they are on COVID, it's likely that they will not make it. They had a higher mortality with ventilator. This is because, the first Italian study which came is that, when they compared two centers, in one center, they did not put any patient on the ventilator, COVID patient. And the other center, they put most of the patients, according to our ARDS protocol, when they put them on ventilator, there was 60% mortality in that center when they put on ventilator. So many authors, many doctors started saying that COVID is not the routine ARDS which we treat in ICU. So it has to be, seen differently. Even when the oxygen level goes down very, 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 very low, we should be jumping immediately to put them on ventilator. So that was the initial finding which we had. And in many countries, we also followed the same thing. Because in those days, pre-COVID days, anybody who actually, gets oxygenation below 85, we will jump and put them on a ventilator. But in COVID, we did not do that. We waited, and only when the patient really required and when they were really, very severe respiratory distress, that is when we actually put them on ventilator. So we had many other strategies in critical care which helped in COVID, which is actually like you would have all seen in WhatsApp, patients going on their tummy and going upside down. That was very, very, very helpful. And then we had many other ventilators and we had something called a Ecmo. Ecmo is, I will tell you about Ecmo. And then we had to just paralyze them and give them ventilator support. And these were the other strategies which were helping us. Now, Ecmo is what we call as an extracorporeal membrane oxygenation. It is a machine which you can see here. This is the machine. The patient's vein and the artery are connected to this machine. So deoxygenated blood will go from here and then go to this machine and go to the oxygenator and take the oxygen and come back to the neck of this patient. So this is called extracorporeal membrane oxygenation. So this machine is actually doing the work of a lung. Okay, so instead of lungs, because the COVID has damaged the lungs, we bypass the blood and it goes to this machine and gets the oxygen and comes back to the patient. So this was helpful in many cases, but it wasn't the magic bullet. You would have known our own favorite singer, S.P. Balasubramaniam. He was on this machine when he had severe COVID, but unfortunately he could not make it. So what I wanted to say is that, that was not a magic bullet. It did not save every life, but it still had a little effect on the COVID. Okay, and then we had many other issues with COVID because the blood pressure will go down to the boots and we have to support it. So we used to use these drugs, what we call as noradrenaline, dobutamine, and then we used these IV fluids which we call as crystalloids. But there were many studies which started saying that you should not use these things. So we had to follow these protocols with COVID. The major thing with the COVID is what we call as it is the textbook definition of emerging infectious disease. It just came. 2019 December is the first time it ever came into the world. It was with the bats or some other organisms, but humans got it only in 2019. So we didn't know what will be the effect of COVID, and so we had to do a lot of juggling within the drugs, and then that is how the critical care was. Actually we could not get a proper protocol for a long period of time. So as I told you, in pandemic we had plenty of patients who required ICU. What to do? There will be like hundreds of patients in emergency department and we have only 10 or 20 beds in ICU. How do we triage? Triage is how do we select, how do we prioritize patients to admit into ICU, and how we can do it by proper ethical protocol. Somebody should not say that, I was denied ICU because of so reason. So how we can triage it? So that was a big headache throughout the world. Actually, they didn't know what to do. In Italy, sometimes they said, okay, anybody above 75, I'm not going to take it in. Those were not actually the correct protocol, but we had a lot of decision support tool. So we actually used the disease-specific criteria and then general physiological reserve of the patient, how much they have, what was their pre-COVID, ambulance, whether they were doing everything on their own, so these are the things which we saw that. And then what we have to see in the COVID in a critical care is survival, whether the patient will be able to survive. Because if the patient is just having COVID and no other problems, they have a higher chance. So survival was one, and the quality of life is another one. Quality of life is that, if the patient who already had a cardiac arrest and we are putting them on all this life support, when they come out, they will be like a vegetative state. That is not a good quality of life. So we were looking at the reasonable quality of life. And also how much resources we have. Because it consumes critical care is a very expensive specialty, and I have done a lot of research on the costing of critical care as a health economist. I will show you some slides on the cost. So resource consumption is extremely important. And then we use some scoring systems like this to see that, if they have all these criteria, okay, this respiratory rate and all that, age and everything, and then if it goes above 3, we used to admit them. So below 3, we will wait. So these are some of the triage scoring system which we used. And then when we had certain criteria, we will actually discontinue ICU support, critical care for these COVID patients, because when they were very down to the boots, the blood pressure is very low, there is no improvement in oxygenation, and then more than 4 organs are failing. Those are the patients we don't actually continue ventilation and continue critical care. Same thing with other things like congestive heart failure, kidney disease and chronic lung disease, and then if they had terminal AIDS with a CD4 count, very low CD4 count, and active cancer, and then cirrhosis of liver, and then severely neurologically impaired patients. These are other criteria which we used to filter them. But now, this is the experience of COVID and a critical care. But what is our goal of medicine? What we need to do in medicine? Is it that, everybody has to survive irrespective of the quality of life? That is not our goal of medicine. Survival is not. But the well-being of patients, that is the goal of medicine. So we should enable the well-being. I will tell you two case scenarios in my own ICU. 76-year-old man with respiratory illness. We came with septic shock. He was not responding because he had very low blood pressure, and so he developed an extensive stroke. But he was still on ICU for 3 weeks until the end came. Same thing with a 92-year-old lady who had a heart disease and a pacemaker, and she was unresponsive. And she was actually a mother of a doctor, so they could not give up on her. But she was 6 weeks she was on ICU. But how much resources are consumed in this? And this is what I said as abusing critical care. So in the next 45 years, the USA statistics says that the people older than 65 will double. Okay. 1 in 5 Americans will be older than 65 in 2030. So the number of elderly people are going up. I am not saying that old people are not eligible for critical care. They are eligible because in this day and age is just a number. And you know that, from our own doctor and doctors, both of them, they are old, but it's just a number. They are still active and they are doing it. And this is what I said, I'm not biased against old age, but what we are discussing here is whether we can use all the critical care life support in a very terminally dying elderly patient and to prolong the death, which I showed you, 3 weeks, 6 weeks, prolongation in their life, consuming all the resources is not going to make any major difference. That's what I was talking about. So what has happened over the period of time is that, everybody is now taken into ICU and that is where they die. In the olden age, when my grandfather's age, grandfather will be just lying down in the bed at home. Everybody will sit around and then, he or she will pass away. So it was an event, but now it has become a process. Death has become a process. They go into a hospital, they go into ICU, they put on life support. It goes on and on and on, and then they eventually it happens. So everybody thinks that a miracle will happen and so on and so forth. So they are already socially dead when they go into ICU. But what we do is we are waiting on the biological death. That's what is happening. So, but death has become very, very, very explosive term, and everybody is afraid of death. And the worst part, and even in India, it's currently happening, that if a patient dies in the hospital, it is seen as a failure of the hospital, which is not so, which is not correct. What happened, you all know that, hospital is a temple of hope. This came out of an Indian newspaper where actually this gentleman is a doctor who was beaten up because a patient who was in a road traffic accident, motor vehicle accident, had a severe bleeding, and he came into this hospital and he passed away because there was no blood available immediately, and he has already lost so much of blood, and he came in extremis we call it. So what happened is all the relatives ransacked this hospital and beat up the doctor. And this is what is happening. So death has become like this, and then everybody in the society thinks that once a patient goes into a hospital, he or she must survive, which is not correct, because everybody comes into the hospital with different physiological status, and only a doctor will know that whether it will be possible to save a patient or not. But unfortunately, we have a death denying notion in the society. Okay, so, and the other thing is about media. Media is always, propagating all these, misconceptions, because, if you see the TV programs and or a movie, I know of a Tamil movie where this hero will die in the jail, and there is no heartbeat, nothing. They will take them in a bus 60 kilometers away, and then one doctor will be standing with a paddle and then give a shock, and then he will wake up and go and fight the villain, and so on and so forth. So this is how the media and movie are projecting, the critical care thing and the death and stuff like that. So these are things which have changed the mentality of people. So what we are trying to achieve in ICU is that, we have to have people with recoverable illness. Okay? Life support technology should serve as a bridge to recovery, in which a failing organ is supported until the underlying disorder improves. If there is a very, very severe disorder which cannot improve, there is no point in putting them in the life support technology. So there have been plenty studies which show that the life support, life sustaining treatment is unwanted in many cases. And this is called what we call as a Eos Syndrome. There is a story in Greek mythology where this Eos is a goddess who fell in love with a mortal, this guy, Tithonus. This Tithonus is a mortal, is a human, and she went to her father, who is a chief god, Zeus, and asked, I want this immortality for this my lover. So they said, okay, he won't die. The boon was given. But what happened later? This gentleman started becoming old and old and old. She forgot to ask that he should not age. All that she asked is he should not die. He did not die, but he became old and old and old, and she had to put him in a dungeon. So she had to go back and ask that, her father that, please allow him to die. So sometimes in ICU, we have seen that 6 weeks, 8 weeks, nothing will happen. They will be going on treating numbers. Putting this, when the sodium goes up, we give the medication. Sodium goes down, potassium goes up, potassium. So treating numbers, and we don't see the overall quality of life. So that some authors call it as Eos Syndrome of medicine. So there is something called a medical futility, where you have to accept that at one point of time that we can't do anything for this patient. At that point of time, we have to know that any intervention will be futile, and this has to be taught to the patient relatives also, because everybody thinks that, even after losing 3-4 liters of blood in a road traffic accident, when they bring a patient to a hospital, the doctor should do some magic and then they have to get up and run away, which is not correct. Okay? So what happens in our situation is that when some old age people or terminally ill people are put on the life support, we don't want to take it away, because some people have religious belief. They say that, my Christian belief says that I have to hold on to life, whether the quality of life is good or not. So they just want to see the heart beating, which is in their own religious belief. Many doctors have their religious belief. Some people feel guilty about taking away this the life support. Some people are afraid of lawsuit, and then there are many other social factors which we studied and we published in the Canadian Journal of Anesthesia. Now, what are the patient's rights? This is very, very important. Every patient should know, every doctor should know. Okay? A patient can refuse treatment, which is a very well defined constitutional right. If somebody comes to me and say that I don't want your treatment, if I go and treat him, that can be seen as assault and battery according to the legal terminology. So it's a very well defined constitutional right. But just because a treatment is available, the patient cannot come and demand it to the doctor. Doctor is the one who decide this particular treatment is appropriate for your illness. ICU is appropriate for your illness because you have a recoverable illness. I can put you in ICU, you can come back. So I will decide whether you need ICU. Okay? If I decide that the ICU is not going to be beneficial for you, that is not a patient's right, it is doctor's prerogative. Any intervention in medicine is to be decided by the doctor and not patient. Patient can choose. We can give, okay, these are the options. Okay, so in a cancer patient, we give them a choice. There is chemotherapy, there is radiotherapy, there is surgery. They can choose. They can say that I don't want surgery. That is their right. Okay, but they cannot say that I want surgery. the surgeon should decide whether they will be benefited by the surgeon. So that is patient's right. So, when there is a futile case, whether the court will support the doctor, yes, they will support. There is a classic case on Massachusetts General Hospital where the doctors said that, this lady cannot go into ICU because she's not going to be benefited from ICU. And the relatives went to the court and sued the doctors, but the court actually supported the doctors. And even the priest who was the defense witness says, every hospital cannot provide every treatment a patient demands. That is very, very, very important. Because, if everybody comes with the idea that, I go into a hospital, I can demand this treatment. Okay, so there are many, many end-of-life care things. We have something called a do not resuscitate. A patient who is really terminally ill, we put them that, don't resuscitate this patient anymore. And, these are many, many things which we follow in critical care. And there are many patients who actually write that do not resuscitate me. If my heart stops, don't jump on me and resuscitate. So that is called an advanced directive and a living wills. These are all present in many countries. We don't have that, but we can actually defend all of them in the court. Okay, so in the court, every single healthcare intervention and medical intervention will not be there in this law books, but an expert witness will go and tell the judge that whatever healthcare intervention was done is correct standard, and that is exactly what the court will accept. Okay, so as a clinician, we cannot do what nature does not allow. We should go by scientific proof. What nature can happen. We cannot just say I can. I have seen many of my patient relatives will come and tell me, doc, please don't do anything. Just continue. I am praying every day, and my God will bring the patient back. We don't discredit that. We say that okay, you pray, but we cannot. You can hope for a miracle, and as a doctor, we cannot be looking for a miracle. So we have to follow what our professional scientific integrity is allowing us to do. So again, we are obligated only to heal and comfort and not just see that the heart is beating. So that is not our duty, right? So what we need to do is to goal-focused care. We have to effectively communicate with the patients, patient relatives, and you shouldn't be just seeing the treatment. As I told you, sodium goes down, give sodium. Potassium goes up, treat it. That is number treatment. But what we have to do is a goal-focused treatment. What is this patient going to be benefited by critical care? At the end of it, whether the critical care unit, when he or she comes out, whether they will be having a reasonable quality of life. And that is what we have to do. And effective communication is very, very important. And we should avoid bias. There are many studies which say that, when they see a patient with AIDS, cancer, or a black person in the United States of America, they all jump to say that, oh no, no more ICU care. But that is a bias. That should not be there. What I do is that I call for a committee decision. I call the nurse, I call the other doctors, junior doctors, everybody, and then sit and make a decision as to who will be benefited from critical care. And I told you that we have done a lot of research, and you can see that every time only the patients who die in ICU will have much more expenditure. If you see that way, double the expenditure. And patients who have actually had a cardiac arrest before coming into ICU, they are they consume more and more resources. So we need to be very careful as to who we are providing critical care. Okay, but we don't talk to the patient's relatives about the cost, but we need to be aware of the cost of critical care. So what we do is that, we tell the patient's relatives that, we are not going to just toy with the biological parameters, treat the numbers. Heart is failing, just deal with the heart. And lung is failing, just deal with the lung. And this is how the biomedical model has happened with critical care. So what we do is to see a human being as a whole, how much recovery and quality of life they will be. So that is when we explain to the patient relatives. So we did also a study on the knowledge of even medical practitioners, nurses, how much they know about critical care and this type of futile care and non-beneficial care. And the results were like really horrendous. Nobody knows, because this is very complex topic. And so we had to educate our own medical practitioners in this particular critical care topic. So in summary, what you want to take home message is that ICU critical care is only appropriate for recoverable illness. The utility should be clearly established that this patient will have a reasonable quality of life. And then if you decide that the patient may not survive, it's only the prolongation of these biological parameters, we should try and see how we can stop the aggressive care. Then we have to talk effectively to the patient relatives and say that critical care is only for patients who recover, and then we have to educate the community about critical care, and that is the long-term solution. So it's not an easy task, but still we can be able to do it. And thank you very much, Dr. Samaram and Dr. Maru, for the opportunity given to me. And this particular talk I is very close to my heart, because I am so, I was so interested in critical care, and that is why I went and did anesthesiology in Manipal, where I met my wife. But when the critical care is not properly used, I want to spread this message that it has to be properly used, and it should not be, because it's very expensive. In a private healthcare hospital in India, if a patient is staying for 4 or 5 days in ICU, it costs in lakhs, and people are pushed into poverty. And that is why we need to know. It's a complex topic, but thank you very much for the opportunity.
Thank you, Dr. Hariharan. You have given very informative speech given to us, and highly thought-provoking. Thank you very much. By this, it ends this program.
ఈ కార్యక్రమం మీకు ఎంతో నచ్చింది కదా? ఇటువంటి మరిన్ని వీడియోల కోసం 18 కోట్లకు పైన వ్యూస్ సాధించిన డాక్టర్ సమరం మల్టీ ఛానల్ నెట్వర్క్ సమర్పించు గోరా ఆరోగ్యం ఛానల్ కు సబ్స్క్రైబ్ చేయండి. అలాగే ప్రక్కనున్న గంట సింబల్ ని ప్రెస్ చేయడం మర్చిపోకండి.
Please download Samaram multi-channel app and watch your favorite channels from your mobile. App available on Google Play Store, and subscribe to the channels.